Welcome to the United Leukodystrophy presents ADLD with Dr. Padiath from University of Pittsburgh, Dr. Toro from NIH, NHGRI, and Lisa Kinsley from Northwestern University.
Everyone, I'm so happy to be able to be with you today. Obviously, we're a bit disappointed that we could not have our in-person meeting, but maybe this is a silver lining because since it's a virtual meeting, all of us can participate. So we have 1 hour today. I'm going to be giving you a very brief overview, followed by Dr. Camilo Toro from the NIH, who's going to be talking about clinical aspects, and Lisa Kinsley from Northwestern, who's going to be talking about the genetic counseling aspects of ADLD. Okay, so let's start because we don't have that much time. So we're going to be talking for 30 minutes and followed by a 30-minute question and answer session. Okay, shall I start my presentation? Great. Okay, so first of all, what exactly is autosomal dominant leukodystrophy, right? What is a leukodystrophy? A leukodystrophy is a disorder of the central nervous system, which means that it affects the brain and the spinal cord. If you actually slice open a human brain, what you notice is that some parts of the brain look white and some parts do not look white. And a leukodystrophy is essentially a disease that affects specifically the white matter of the brain. Now, what exactly is this white matter? This white matter is enriched in a particular kind of tissue which is known as myelin. To understand what myelin is, we just need to kind of revisit the different kind of cell types and go back to our basic biology of the brain. Now, as all of you know, we've all heard of neurons, right? So neurons are essentially the cells in the brain, and there are billions and billions of neurons in the brain. And this is what kind of a typical neuron looks like. It has what is known as a cell body, and it has this long thread-like structure, which is known as an axon. Right? So the neurons are important in the brain for pretty much doing whatever the brain does, right? Controlling body movements, feelings, sensations, thought, right? So just as an example of neuron that controls movement, right? The neuron, the cell body of the neuron starts in the brain, and this axon goes all the way down the spinal cord, and from there, another neuron's axon goes all the way down to the muscle. Right? And so the way it works is that this neuron here sends an electrical impulse, and this electrical impulse is transmitted all the way down to the muscle. So neurons work by transmitting electrical impulses. Right? So just like copper wires in our home, you know that copper wires are covered by insulation to prevent the electricity from going from one wire to the other. So the same way, these axons of the neurons are also covered by insulating material. And this insulating material is known as myelin, right? So what does the myelin do? It helps us conduct nerve impulses very, very rapidly. So if you can see this animation here, you can see that without the myelin, the electrical impulses go very slowly. With the myelin, the electrical impulses go super fast, and that's really important for us, right? Myelin in the brain is produced by another cell type, which is known as an oligodendrocyte. And you can see here, this oligodendrocyte wraps all the way around the axon and produces myelin and produces this insulating material. Right. One very important thing to remember is that myelin are very, very rich in lipids or fats, and that's why it appears to be white. Right. If you take a glass of skim milk and full fat milk, what you notice is that the full fat milk appears much whiter. And that's because it contains a lot of fat or lipids. So what is autosomal dominant leukodystrophy? Essentially, it's a disorder of the loss of myelin or demyelination. Right? So loss of myelin is the primary pathology in autosomal dominant leukodystrophy. If you look at a brain from an ADLD patient, and this is from a patient who has passed on, what you notice, so all this should look white. It should look exactly like this here. But you can see that some areas look gray and they do not look white. Right? So we all know ADLD is a genetic disorder, right? So let's just revisit our biology 101 to understand what that means, right? We all know that, all the body contains different organs, right? And each of the organs is made up of cells, within each cell is a nucleus. Inside the nucleus are the chromosomes, right? And we all know the chromosomes contain the genetic material that we get from our mothers and fathers, right? Chromosomes are essentially long pieces of DNA. right? And this DNA is organized into structures which are known as genes. And genes code for proteins. And it's the proteins that really carry out all the functions in the cell. So we might have a protein that codes for an enzyme that helps digest food, or we might have a protein that codes for eye color, right? So what happens, so just a little bit more about chromosomes, right? In humans, there are 23 pairs of chromosomes, right? There's one chromosome from the mother, one chromosome from the father. Females have two X chromosomes, whereas males have an X and Y chromosomes. And these chromosomes are known as sex chromosomes. All the chromosomes which are not sex chromosomes are known as autosomes. And that's where the word autosomal comes from in autosomal dominant leukodystrophy, right? So what is the genetic defect in autosomal dominant leukodystrophy? So in 2006, we identified that autosomal dominant leukodystrophy was caused by a mutation involving a single gene. That's just one gene on chromosome 5, right? So chromosome 5 is here, right? Normally, each of us has one copy of this lamin B1 gene. So we all have two copies, one from the mother, one from the father. In ADLD, what happens is that patients have an extra copy of this gene. And this is known as a gene duplication. So ADLD patients have a duplication of one copy of the lamin B1 gene. What that means is that patients have 3 copies of the gene, whereas normal individuals have 2 copies of the gene. So this is just another way of showing the chromosome, the lamin B1, and you can see that patients have an extra copy of this lamin B1 gene, and in most cases, it's inserted next to the original copy, right? So since we understood the genetic defect, right, and one important point to note is that every family has a different size of the duplication, right? So the duplication sizes are unique to each family. Right? So since we identify the genetic defect, there is a very, very robust genetic test to test for lamin B1 duplications. Right? So we can test and tell you unambiguously if you have a duplication or not. Right? So what happens because of the duplications? What happens essentially is that because of this extra copy, there is more amount of the lamin B1 protein. So this is really important to remember. We really think that the basic pathology, the basic mechanism is having too much of this lamin B1 protein. So let's understand now what this lamin B1 protein does, right? So lamin B1 is a long filament, so it's a thread-like protein, okay? And these threads kind of form a meshwork, just like you see here. And this meshwork is specifically present only in the nucleus. What does it do? Right? Just like rebar in this concrete, this meshwork of the nuclear lamina is thought to provide structural support to the nucleus. So it kind of gives support. So if there's no lamina, the nucleus just kind of collapses. And it's also very, very important in organizing how chromosomes are distributed in the nucleus. Okay. So since we identified the gene in 2006, we've identified patients and families from all around the world. You can see pretty much a lot of the many countries have ADLD. So it's not restricted to a specific ethnic group or a specific racial group. Okay, so what are some of the questions that we are asking to understand this ADLD disease mechanism? Okay, the first really important question is that this protein lamin B1 is present in pretty much all different kinds of cells, right? So why does it cause only a demyelinating disorder? So that's really a curious question. We're trying to understand that, right? If the duplication of this lamin B1 gene is present from birth, why do only people get it when they're about 40 or 50 years, right? And importantly, how does lamin B1 cause demyelination? There was no clear answer at all, right? Importantly, if ADLD is caused by more amount of lamin B1, can we reduce lamin B1 and use that as a treatment for the disease? If we can do that, at what age should the treatment start, right? And extremely importantly, can we find drugs or specific molecules that can reduce lamin B1 levels? So to do this in our lab, we use different kinds of tools, which are equally important. Right? We use cells from ADLD patients. I might have gotten cells from some of you who are listening. Brain tissue. This is extremely important. Some of you have been extremely generous. When your relatives pass on, they have been donating brain tissue. And very, very importantly, we use mouse models. And the reason for this is obviously you cannot do experiments on humans, right? So if you have to understand ADLD disease mechanisms or or device treatments, we need to have some model that we can do experiments on. And we are lucky to have a really good experimental mouse model. So you can see here, this is a mouse which is about a year of age. Mice usually live to about 2 or 3 years, and you can see that it has serious problems moving. Right? If you cut open the brain of the mouse, you can see it has a pathology very, very similar to ADLD patients. So this is an invaluable tool. This is just its normal sibling. So this is an invaluable tool to understand both the disease mechanisms and to test treatments. So one of the things we've really identified using these mice is that it seems that when we produce more amount of lamin B1, it seems to reduce the amount of lipids, right? And remember, I told you myelin is a tissue enriched in lipids, so that kind of makes sense. Okay, so what are we trying to do to develop therapeutic strategies or therapies for the disease, right? We are working on the principle that the one thing we know for sure is that more amount of lamin B1 causes ADLD. So most of our therapeutic strategies are directed towards reducing lamin B1 levels. We are using two different approaches. One of them is using a kind of molecule known as antisense oligonucleotides. Right? These are molecules which are specifically designed to reduce protein levels. We are collaborating with a company known as Ionis Pharmaceuticals to test these ASOs in our mouse model. Ionis is a world leader in antisense oligonucleotides, and many of the ASOs they have used for other diseases are already in clinical trials in humans. Our preliminary work with the ASOs in mice looks very promising, and we are continuing that. We're also working with the Drug Discovery Institute at the University of Pittsburgh to specifically identify small molecules that can reduce lamin B1 levels. To do this, we have a system where we can screen hundreds and thousands of molecules using a robotic assisted system. So obviously, we don't have enough time to go in detail, but I just want to kind of give you a flavor of what the disease was, some of the research topics and some of the topics that we are working on to identify therapies. I'll stop there. I just want to acknowledge my lab. As you can see, there are a lot of people, some have left, some are still there, who are working on this. Many collaborators all around the world, the funding agencies, and most importantly, I think I want to thank all you patients, because it's really your continued support that helps us push the research forward. So I'll stop there and I'll hand it over to Dr. Toro from the NIH.
Okay, so thank you, Quasar. That was a very exciting presentation, and thanks to all of you for being present in this presentation. My intent, and maybe let me go one slide. I think there's a slide before this one. If we could move backwards one. If not, we can just go ahead. I'm a clinical neurologist. I work at the National Institutes of Health, and my work is in the diagnosis of rare diseases. And I've had the opportunity to work with Dr. Padiath in patients with autosomal dominant leukodystrophy. I envision introducing my presentation as sort of putting myself in the shoes of a person that has been given a diagnosis of autosomal dominant leukodystrophy, and I can envision two possible scenarios. The scenario of a person that has a very clear family history, and as a result are probably experts already at the disorder, and are probably going to be teaching their physicians about this disorder, or the possibility of a patient that is diagnosed what is called de novo, meaning the disease wasn't known to exist in the family, or the family history wasn't clear, and as a result, you know, there is sort of a journey, a process of education to you and to your physician related to this. And this is the big secret. We all do it, even physicians do it. We all go to Google, and the first thing we do is we enter the words autosomal dominant leukodystrophy and try to understand what is this disease about, what are the symptoms, what are the typical features. Most likely, and I'm going to show you my next slide, that this is not moving forward. Let me see, what is my problem? Can you see my slides? For some reason, I am not
See your slides fine. You may need to click the window, and then you can use the controls at the bottom of your PowerPoint window, or use your arrow
Should I
keys.
close this one? Let me see.
Yep. Use your mouse and just down on the bottom. Yep. Use your arrows right there. Great.
So most likely, a diagnosis of autosomal dominant leukodystrophy has basically occurred in the context of having a variety of symptoms and eventually going through a number of different specialties, being told that a variety of diagnoses, not uncommon, patients are told that this is a variant of multiple sclerosis or a disease that is really unclear to your physician. Eventually, it comes to the point that somebody performs an MRI of a patient with autosomal dominant leukodystrophy will look like the group of images to your left, and you can see all that bright white matter signal that actually is not present on a normal MRI. And based on this information and based on the clinical symptoms, the decision is made to have the testing. And the testing, as Dr. Padiath mentioned, is very robust and provides almost inconclusive, controversial evidence of whether or not the disease is present or not. The arrows here point to places that are relevant to what we're going to discuss later on, basically areas of abnormal myelin signal on the MRI that are going to be relevant to clinical symptoms. So my attempt here is to try to go through the symptoms with you and tease out some of the components. What do they mean? How do they present? And how can we make a difference? Because I know, there are a lot of aspirational goals and actually a lot of goals towards a disease modification or cure that are in the works. But in the meantime, there is actually an important element in managing symptoms, because managing symptoms changes quality of life and could actually result in a substantial difference. So the symptoms of autosomal dominant leukodystrophy usually can be divided into autonomic dysfunction, usually is the very first symptom, and we'll talk about them, pyramidal or upper motor neuron symptoms, cerebellar symptoms, and cognitive issues. There are additional symptoms that may develop, but these are the cardinal sort of features of the disorder. What is the autonomic nervous system? So you hear about dysautonomia. What does it mean? So it turns out that there is a substantial part of our bodily functions that are totally autopilot. So we don't control our temperature, we don't control our blood pressure, we don't control our temperature, bowel movements, the urge to urinate, and so forth. Those are all functions that belong to what is called the autonomic nervous system. And it's divided into sympathetic and parasympathetic. And many of the neurons involved in that reside within the spinal cord. And those functions are actually very often the initial target of autosomal dominant leukodystrophy. Main symptoms from these manifestations include dysfunction of the bladder, and that we're going to go into detail through that, constipation, the presence of what is called postural hypotension, meaning your blood pressure drops every time you are presented with the forces of gravity when you stand, erectile dysfunction in males, and impaired sweating and thermoregulation. And management of these conditions could depend on the variety of symptoms. So the bladder could be overactive, meaning it wants to empty with minimal distension of the bladder. It could be flaccid, meaning the bladder is unable to sense that it's fully distended and could be liters in volume and you still don't have the urge. Or it could be a bladder where the different muscles of the bladder, the one that basically contracts the bladder and the one that is the sphincter, they are kind of fighting against each other. It's called a dyssynergic bladder. There are medications to treat these. There are studies to decide which of the flavors of urinary urgency it is, and the treatments could be very effective and make a big difference. Constipation common, and when combined with urinary urgency, a lot of patients decide not to drink because they are concerned about urination. So it kind of makes constipation worse. There are a number of different strategies to manage that. Postural hypotension is also an issue. Patients may faint when seated or when standing. And there are strategies to deal with that, including ensuring proper hydration, liberalizing salt, use medications, compressing stockings. Erectile dysfunction is very common. One of the first things that one considers is any of the medicines you are using the source of it rather than actually the disease itself. But if not, then there are strategies that could be considered. Impaired sweating and thermoregulation is common. There are patients that are extremely heat sensitive, and the summers are terrible in the sense that it worsens the symptoms. And it turns out that simple strategies as ensuring your house is kept, 65 to 70 degrees, that you drink cold fluids, that you use cooling vests, that you have good air conditioning in your car could actually be the source of substantial improvement. Pyramidal symptoms. So in neurology, people talk about upper and lower motor neuron. It means that controlling muscles requires two main neurons. The one that sits in the motor cortex and has these long extensions that Dr. Padiath referred to as axons. They are all covered in myelin, and they go to the spinal cord, where there is a second neuron that is called the lower motor neuron. In autosomal dominant leukodystrophy, is the upper motor neuron that is affected. Not only in the brain, the sheets of myelin are involved, but also throughout the spinal cord, as noted here on this MRI image of the spinal cord. That bright signal indicates abnormal myelination. Typical symptoms: spasticity, that means muscle tightness; weakness, in this case, meaning lack of control on the muscles, not necessarily that the muscles are wasted. It's more like the brain is unable to make the right signal to the muscles to contract. Spasms, often painful, very brisk reflexes that leads to the legs bouncing or jumping on their own, and sometimes abnormal postures. There are treatments for each one of them, and I really will encourage the message that you really, to manage these things, there is a need for a team approach where your physical therapists, your occupational therapists, your physiatrists are heavily involved to decide what medications will be the proper medications to manage each of one of these. I should mention too that abnormal sensations are not uncommon in patients with this disorder. Often they have a sensation of tingling, numbness, sometimes burning, pain, and there are medications that could help that, and that may result in improvement in quality of life. Another symptom that is mentioned very common is cerebellar dysfunction. The cerebellum, and I noted here image of a patient with change in the myelin in this part of the cerebellum called the middle cerebellar peduncle, where a lot of the information to the cerebellum goes into, is affected in this disease. Well, the cerebellum is this very, very heavily organized modular structure that is critical in the control of movement. So our timing of movement, coordination of movement, speed of movement, accuracy, all these things are regulated by the function of the cerebellum. If that input to the cerebellum is degraded due to the changes in the conduction velocity or the quality of the signal because of the demyelination, then you have ataxia, incoordination, slurred speech, tremor, and so forth. And we'll go through them. So ataxia means lack of balance or lack of coordination, mostly related to gait. So patients have a base of support that is wide, they kind of veer to the sides, they need to hold on to walls of furniture. And there are strategies to deal with it. Again, some of them related to occupational physical therapy, adaptive equipment, and so forth. Tremor is not uncommon. It's a kind of tremor called kinetic tremor or cerebellar tremor. Usually is worse when you attempt to do something. Turns out that speech requires the coordination of many muscles at once. So it's not uncommon that patients with this disorder have issues with speech coordination, something called dysarthria or slurring of speech. If it gets to the point that the muscles that involve swallowing are also impaired, then there may be issues swallowing liquids where the liquids go the wrong way, make you cough or upchoke. Nystagmus is basically sort of a jerky eye movement. Very often patients are unaware of it. Sometimes they perceive the visual space as having some jittery, sort of oscillating movements. That's called oscillopsia. Finally, Cognitive issues in autosomal dominant leukodystrophy are present. They tend to occur later in the disease. But if you think of our cognition, usually related primarily to functions of the brain cortex, are really the integration of the inputs from many, many, many different parts of the brain. One looks at this image with a high resolution, you can see that there are like tiny little hairs all over the surface of the brain. Each one of those could represent actually part of a pathway. If those pathways, and including the middle bundle in the middle, is called the corpus callosum, each one of those pathways has axons. Those axons are connected by are covering myelin to improve the connectivity. And if that connectivity is impaired, the capacity to basically coordinate the functions of this amazing computer are out of timing. And it's not uncommon to have what is called executive dysfunction, difficulty planning, this cognitive slowness. There could be cognitive decline. But also keep in mind that, I mean, this is a tough disease, and depression and anxiety could be actually common elements of a response to a disease like autosomal dominant leukodystrophy. So in closing, I will say that there are strategies to address these things. Again, having a team and a physician that is willing to listen and work with you will be critical in managing some of these things. Reviewing medications, avoiding social isolation, tapping on available resources, counseling, etc., could actually make a world of difference. So in closing, I will just add these remarks. First, autosomal dominant leukodystrophy is extremely rare. It's very likely that your physician had never seen one and probably will never see one unless it's somebody that has worked with the family. The clinical course of this disease is dynamic. What worked at some point in the past may not work tomorrow. We don't know much about it, so what makes it better or worse, what is responsible for sudden worsening is not quite clear. We know that infections, high fever, can give you a temporary worsening that sometimes may not unlike multiple sclerosis, may actually stabilize. It's not uncommon to be concerned about issues related to employment, insurability, genetic risk to relatives, and prospects of independence. Those are totally human responses and things that should be carefully considered. The care should be individualized, so what works for one person may not work for the next. And it's important to consider, at least from the medical management aspect, to think about what works in other, I call it like disorders. So we know things that work, cerebellar ataxia of different kinds, so implement those things. We know what works, management of temperature dysregulation and symptoms in patients with multiple sclerosis. That could help patients with leukodystrophies. But more than anything, I really say that what you're doing right now is critical, that advocacy organizations in rare diseases are really the main drivers for change in finding alternatives and strategies that will certainly make a difference in this type of disorder. So with that, I will conclude my talk and look forward to questions during the question and answer session. Thank you.
All right, thank you so much. I am going to review some information about inheritance and also some options for family planning for patients and families who have one of these diagnoses. So just to touch a little bit on the inheritance, we had a genetics primer earlier in the session, but we know when things are genetic, they can be inherited, and just a little picture here to illustrate that. So these are variants that can be in the egg DNA or the sperm DNA. When those two combine and result in a fertilized egg, that variant is present in all of a person's cells. So that's one of the reasons that we can do like a blood test or a saliva test to get a genetic diagnosis for a person. The gene is located on chromosome 5. So this is chromosomes that are shared between men and women. This is also a gene that everyone has. Whether or not someone has this diagnosis, everyone has, 2 copies of this gene that is making that protein that we discussed earlier. So when we think about autosomal dominant inheritance, autosomal means that it is on one of the autosomes. So the autosomes are the non-sex chromosomes, the first 22 pairs. And when something's autosomal, that means that males and females can both be affected because we all have chromosome 5. That also means that males and females can pass ADLD to their children. When something is dominant, that means that we have that 50% risk to each child. And dominant essentially means that only one of those copies of the gene need to have an alteration in order to put someone at risk to have symptoms. So when we're talking about inheritance, if someone doesn't inherit this genetic variant from their parent, they can't pass it on to their children. You can only pass on what you have, and if you inherit 2 working copies of this gene, that's all you're going to pass on. I know people talk a lot about things skipping generations in genetics. It's not the case here. It's not something that can skip over you and pop up in a child, which is helpful to know when someone's pursuing testing. Each child of a person with ADLD has an independent 50% risk. So this isn't changed by their sibling status. If someone has 2 kids, it doesn't mean that one will have it, the other one doesn't. We often talk about dominant risk as like flipping a coin. So it could, if you flip a coin twice, you could get 2 heads, 2 tails, 1 of each. It's independent of the other flips, essentially. So then just to illustrate the autosomal dominant inheritance, we have, just looking at chromosome 5 here, if we have peach parent who has two chromosome 5s and one of them has the variant causing ADLD, purple parent has 2 working copies of that gene. We know purple parent is always going to pass on a working copy of the gene. The issue becomes which copy is peach parent going to pass on, the affected parent. So half of the time, half of the possible combinations will be 2 working copies of the gene, which would mean the other two possibilities are that child inheriting that same variant. So we get the 50% of those possibilities for an unaffected individual and a 50% chance for an affected individual. So this is kind of an example pedigree. I take a lot of pedigrees in my job, just trying to determine inheritance and patterns in families. So squares are males, circles are females, different levels are the different generations. And if someone's colored in, that means that they have the symptoms or the disorder that we're tracking. So what I'm seeing here is we have multiple generations that are affected. Males and females are both affected in the family. It's kind of what we had talked about with autosomal dominant inheritance. So there is testing for ADLD. There's kind of 2 different categories. So diagnostic testing is when someone has symptoms. We're trying to find an answer for why they're having those symptoms. It's fairly straightforward, but it can still be hard information to get if someone has children or family members who are at risk, or they're, concerned about getting that diagnosis. It's important to talk through those issues before we do that testing. On the other hand, we have pre-symptomatic testing. So this is for people who are at risk for developing symptoms. They maybe want that information for a variety of reasons, but we essentially need family members' information for this to even be an option. We want to make sure that we're testing that person for the right thing and that we're giving them that solid yes or no answer about whether or not they inherited that genetic condition in the family. So this testing is a lot more likely to have psychosocial implications. It's a hard decision. Most people who are at risk choose not to get testing, but there are people who do for a variety of reasons. So we just want to make sure that people are set up to receive that information in the best way possible and just make sure that they're prepared for what testing can and cannot tell them. So testing protocol, you'd probably meet with a genetic counselor and a neurologist. There would definitely be talking, pre-test counseling before we order the testing. There might be a neurological exam. We would then meet again for the results disclosure. Really prefer to do that face-to-face. It's not something that you want to just tell someone over the phone. And then any post-test follow-up, if there's, support groups or any, research participation, other things that we could discuss depending on those results. One of the things that makes this a really hard decision is that we can't prevent or predict the symptoms or the onset for this or any number of adult onset conditions. So we can't, it gives us limited information, but it's not a crystal ball. It won't tell us the exact age of onset, what type of symptoms we're going to see first, or how the disease is going to progress exactly. So it's information, but it is limited. So some of the things that I talk to people about when they're deciding to test is, the timing of testing. Is it a really stressful time in their lives? Are they just getting married? Are they in the middle of grad school? Things like that can have different implications for getting the testing, who they're going to tell the results to, kind of what their support system looks like, what effect that might have on their spouse, their siblings, their parents, their children. It can have effects on all those different relationships, and whether or not they have professional support. So obviously I'm a part of their care team, but if they have a therapist or anyone else in their life that is helpful in that side of things. There may be insurance issues. People usually have questions about insurance discrimination, employment discrimination, what that means with a genetic test. So really recommend that people have life insurance prior to testing. Things like health insurance are covered and protected by the Genetic Information Non-Discrimination Act. But there are some things that we'd really prefer people have in place before they go ahead and get the testing. People can be concerned about a loss of privacy, about having that information or other people having that information, and just wary of how is this going to change the family dynamics. It can change both of its positive and its negatives. So really just kind of walking people through that to prepare them for what those changes might look like and how they can deal with those and continue their lives. Some of the reasons that people consider doing pre-symptomatic testing, I think the most common one would be family planning, and I'll talk a little bit more about that with the next few slides. People also want information about their genetics for career decisions. Maybe they would, not go for a promotion or, go back to school. Different things like that, not go for a promotion, go for a promotion. Financial planning, just to plan out for the different scenarios. Some people just want to know because they're anxious all the time and they think that everything is a symptom, which is understandable. Other people are really interested in research and clinical trials. So this is all things that genetic testing could help with knowing down the line. So I'm going to walk through some of the reproductive options for when we have a known genetic condition in the family. So prenatal testing is definitely an option. So this is getting pregnant naturally and then either taking a very small sample of the placenta or the amniotic fluid, depending on how far along the pregnancy is. And they can actually do the same genetic test to determine from the pregnancy skin cells to determine what the status is. So I kind of made a list of pros and cons for each of these, and these are very, subjective. So things that are pros or cons to one person may not impact another person's decision. So I just try to throw out everything that, I've heard of and talk to patients about. But in general, this method does greatly reduce the risk of passing on the disease. It is a natural pregnancy, quote unquote, whatever that means. Biological relationship with the offspring would be there. And it's generally less of a financial burden than some of the other options that I'll talk about. Cons, people may have ethical considerations. Usually getting testing like this would come along with a decision about whether or not to continue a pregnancy. Costing is going to vary. It depends on, insurance coverage and where you are. The procedures do carry a small risk of miscarriage, which kind of varies from place to place where it's done and an actual practitioner, but that is something to consider. And it also could reveal an untested parent status. So there are some methods where we can say, we can do testing and not reveal whether the parent has it or not, but this is not one of them, because if we test a pregnancy and it's positive, then we know that the parent who is at risk is positive as well. Adoption is also an option. Obviously, this would reduce the risk of passing on the disease. Another pro would be, helping a child or family or woman who is in need. Some of the cons is this is an expensive process, $20,000 and up. It's a long process. There isn't a biological relationship depending on the adoption, if that's important to a couple. And then there's also the potential for long-term consequences of adoption. So there's also the option to get a donor egg or sperm. So this would also reduce the risk of passing on the disease. It might involve any number of medical processes. It could be, as involved as IVF or a surrogacy. It could be artificial insemination. Costs definitely vary. Donor eggs are more expensive than donor sperm, so $8,500 versus $500 about. These are kind of estimates depending on where you are. And then there would be no biological relationship if that is something that's important. So usually the one that patients are most interested in hearing about is pre-implantation genetic testing. So this is also called PGT. It used to be called PGD, IVF with PGT. And this is basically a method of screening embryos for a known genetic condition. So we have to do PGT in conjunction with an in vitro fertilization or IVF cycle. IVF literally means fertilization in glass. Historically, you might have heard of, test tube babies. There's not many test tubes involved, but that's kind of the mental image that people have when they hear about IVF. So just to briefly run through the processes. So there's a lot of testing and setup beforehand so that the lab can do the testing on the schedule and the scale that's necessary for embryo testing. There is an egg harvest, so that the woman is given drugs to produce as many eggs as possible. Those are extracted. Each egg is fertilized and allowed to grow for a week, 2 weeks, depending on the center. And then they can actually do a very small biopsy and remove a few cells from each embryo and do a genetic test to determine which copy of each of these genes each embryo inherited. So they'd essentially know the status of each embryo. So, you're hoping for as many embryos as possible. There's that 50% risk that could, reduce those numbers. And then at the end of things, when we have, the results, just looking at which embryos are developing well and which are eligible for implantation. So hopefully there would be embryos as an option. Those would be inserted via catheter, hopefully resulting in implantation, and then hopefully resulting in pregnancy. So that's kind of a brief overview. If someone is undergoing, IVF and PGT, there are genetic counselors that specialize in that you would definitely be meeting with to talk more about the details for each case, because everyone is different and there's, different things that go into that. So pros, this also significantly reduces the risk of passing on the disease. There is non-disclosure testing, so we don't have to know a parent's status before we can offer this. It's a little bit more setup involved, but it's a possibility. There's reduced guilt, you're not worried about passing that on. There's no increased risk of birth defects from the embryo biopsy. It doesn't, affect the embryo down the line. There would be a biological relationship, and this is generally a more acceptable option for couples who are at risk who wouldn't consider terminating an affected pregnancy. Some of the cons, this, like a lot of genetic testing, is considered experimental by insurance companies. The maximum accuracy is usually around 98%. The testing process can fail, and there's usually an indication of how accurate each test is for each embryo, but that is a possibility. There's emotional and ethical considerations. It's a tough process. It's a lot of injections and, highs and lows, and it's important to work with a center and a doctor and a genetic counselor who you're comfortable with. But there's definitely ethical considerations. It's not a perfect process. So, coming up with a plan for what to do with affected and unaffected embryos is something that's a part of that initial setup meeting. It doesn't always guarantee a pregnancy. The take-home baby rate isn't 100%, and that varies from person to person, and they'd be able to give you more specifics based on your specific situation. Another con is we can't predict the future. We don't know what the future will look like when babies who are born now will be at risk for these symptoms. It could be that there will be something that we can offer and something that we can do. So that is, a risk for any of these, or a con for any of these rather. There is a risk for prenatal testing, which they still do recommend, just to kind of double check the PGT testing process. There's a risk for multiple births, involves a lot of different processes, and it's very expensive. So it may or may not be covered by insurance, but going over those numbers and trying to figure out insurance coverage is something that is really important to do before undergoing these procedures. So I just wanted to throw in, there is a consensus statement from the American Society for Reproductive Medicine that basically said, PGD for adult onset condition is ethically justified when the condition is serious and no safe, effective interventions are available. So it's definitely recommended that a genetic counselor is involved to make sure patients know what they're getting into and to kind of be the guide through the process. But those are some options for patients who are at risk or know their status and want to have kids and not pass that on. So I'm happy to answer any questions. I think we're heading into the question and answer session, so I'm more than happy to answer any questions that people have.
Okay, thank you so much, Lisa. I really appreciate you and Camilo taking the time to talk about this. So just a few brief things. Unfortunately, we don't have a huge amount of time, maybe another 15 minutes. And I just want to throw out there that, because there are so many questions, and now we are all experts at, managing virtual meetings through Zoom. I would be happy at some point in the future to have another virtual meeting where, more of the questions can be answered. So I just want to throw out there. So we had a few questions that I had you had already sent me earlier, and then a few people are asking questions over the chat. So I might summarize a few and then just let each of you guys answer respective questions. So there was one question about advocacy groups one of you had asked. So I just wanted to kind of announce that one of the families, I think, spearheaded by Mr. Inderpal Singh, is actually trying to set up an ADLD center. So I guess this will be a virtual center, but I can email you, the website so you can kind of look at it. I think it's just in the process of being set up, and I think it's really important, like Dr. Toro said, that patients really advocate as much as possible. This makes a huge difference, in terms of when we are kind of approaching pharmaceutical companies, when we want to carry out clinical trials. So I think that's really, really important, and I think it's a really important first step that one of you is trying to set up this advocacy group, and I hope everybody will be involved in that. I will definitely be supporting it as much as I can. So that was a question about advocacy groups. So Camilo, one of the patients had a question about, are there any specific disease organizations that an advocacy group can approach? Would you know of them?
So there are a number of organizations. Some of them actually are fairly well structured to help communities of patients with rare diseases beginning the process of organizing support organizations. So NIH has something called the Office of Rare Diseases Research, and you can Google it, and you'll see that they have actually a structure of and some pathways for organizations to be created. There is also an organization that also is all-encompassing for rare diseases that is called NORD, the National Organization of Rare Diseases. So those tend to actually be helpful, kind of creating the blueprints of how to move forward with a disease-specific organization in rare diseases.
Great, thank you, Camilo. And I can send an email out with websites, with links to those websites also, the two ones that you've mentioned. So another question was specifically about genetic testing. And I think there's some concerns. I think one of the people had mentioned that you have to be cautious about insurance and genetic testing, that you want to get insurance before genetic testing. And another question was whether, if you are getting tested, what advice would you have about asking family members before you disclose ADLD status? Because obviously other members might also be at risk. So Lisa, maybe you could answer those.
Yeah, I think, when we're talking about insurance coverage, if someone is interested in any policies, even if it is something that's covered by GINA, I really would recommend getting those in place before pursuing the testing. It depends on how you're getting that policy, if it's through work, if it's something you're pursuing independently. It's really going to depend on, what kind of questions they're asking and how up they are on, genetics of different conditions. But in general, you're going to want to get any policies or anything before you start the testing process. And then in terms of, talking to family members, in general, really prefer to see, open communication. It's tough when, trying to keep a secret like this, if you're trying to withhold your status from family members, if you're trying to, not tell people for any number of reasons. So I think that's definitely something to talk about in the pre-test counseling session. One of the questions I ask is, who are you going to tell about the results? Who aren't you going to tell about the results? So that's just me trying to feel that out to see if there is any, blocks there that someone you're not going to talk to, that we can just kind of talk through that and see why that is and how that could have effects down the line. So I think in general, like I said, open communication and everything kind of out on the table is definitely more recommended, but I totally understand that there are family circumstances that don't allow for that or would not make that the best decision. So it's going to vary from person to person, but something to bring up in the pre-test counseling for sure.
Okay. I just saw another question asking, what are the average cost of testing? Does insurance companies cover it?
It's going to depend on your specific insurance policy. In general, I can get testing covered for people for under a few $100s. It's usually something that we can do benefits investigations before we send out the testing, so it's not a surprise bill. You'd basically know what the cost was. But I would imagine the self-pay would probably run $200-300 depending on the lab.
Okay. So there were a few other questions specifically talking about, more research-oriented treatments. One question was asking, are there any clinical trials, or how far away are clinical trials? Another question was asking about CRISPR, which is a very recent kind of DNA technology. So I think, the kind of cautious and conservative answer to that would be that all of these are still in progress. We are still in very, very early stages. We don't know if some of the therapies that we are using in the mice even work. So I would say that, we are maybe 2 or 3 years away from trying to figure out if the therapies work in mice. And from there, it takes another at least 5 to 10 years for clinical trials. So it is not an immediate process. We are working on it. Some of our results are promising, but it's not something that is very immediate. And especially for something like CRISPR, although it's an exciting technology in the lab, it's still many years away from using it in the clinic, and especially for a disease like ADLD. So we had some other questions specifically about, one of the questions was about Ionis Pharmaceuticals, what are the milestones? And I think one of the things we are doing is, like I said, to see if the ASO therapy works in mice. If it does work in mice, then we would go for the next stage to see if it is safe in, phase 0 or phase 1 clinical trials, and then kind of go from there. So those are the questions. So that kind of answers the question about the Ionis Pharmaceuticals. So I think you've already, Lisa, covered some questions about ethical implications. So one of the questions specifically, I think, were the ethical implications of testing children of affected parents if they're carriers. So they don't have the disease. Obviously, they're too young. So could you talk a little bit about that?
Yeah, so in general, it's really not recommended to test children for adult onset neurological conditions. The main reason is that, there's not anything we would do differently. It's not something that we would initiate a treatment for at this time. If there is a treatment, that might change in the future, but right now it's not anything that we would change about their care or, their lives at all. It also kind of takes away their right to know. So I kind of mentioned in my presentation that a lot of the people who are at risk choose not to have testing. They don't want to know their status. And this kind of takes away that child's right. They can decide if they want this testing when they turn 18. If it becomes something that they want to know, then they can pursue that on their own. But having the parent kind of order that testing really just takes that choice away from them. And I know it's frustrating, and I know it's hard because that there's that 50% risk, but it's just really not recommended for a lot of different reasons.
Okay. So some of the questions are coming in, some of them about treatments for ADLD. And there's some questions about is there any treatment specifically to stop the demyelination? for ADLD? That's one. The other question is, can any existing medicines be used to treat ADLD? So I think you and Camilo talked about the fact that, you should look at some other diseases and see if they're similar and see if you can use some of the treatments from there. So could you speak to that a little bit?
So it's correct. So people have asked the question, would medications, for example, that work in multiple sclerosis could work in this disorder? This disorder, by its own biology, is not like multiple sclerosis in the sense that there's really not an immune response responsive to the myelin. So I would say that we do not know of available medication that could stop the demyelination. We are aware of a number of strategies that could help the symptoms of demyelination in terms of, for example, we know that patients with multiple sclerosis are very sensitive to temperature and get a lot of worsening of symptoms in the context of infections, in the context of fever. So the same approaches that one could use in MS could be tried in some of these medications, because many of the symptoms mimic those of more common diseases like multiple sclerosis or spinocerebellar ataxia. So my idea was to basically find a physician who, or a team that will be willing to learn with you, learn from you, and learn for you in terms of exploring options, because in terms of symptomatic management, everybody's different, and the response could be substantial in some cases, and I think it's worth a trial.
Great, thanks, Camilo. So we have a little under 5 minutes left. So I'll just answer. I don't know how many more questions we can answer. So the other question is, what can the patient community do to advance the work? So I think it's really important, first of all, that the patients be involved. Like Camilo said, this is a rare disease, and patient advocacy really is what pushes the research forward. So I think, first of all, just being involved, being part of kind of the research, part of the discussion, I think starting this patient advocacy group and this website would really, really be helpful. We are conducting a study, a natural history study, and some study about educational materials. So, when you do get emails from obviously a reputed source, please be involved in the research. That makes a huge, huge difference. And feedback. So, Camilo, please go ahead. You want to say something?
So I will add to, and 100% endorse that, is that many times, in order to determine the efficacy of a future intervention, you need to know very carefully what is the natural history of it. How does it change? How does it progress? What is the trajectory that the disease follows? And if that information is already generated ahead of time, that information actually can serve as the basis of a control group. That is something that is very, very powerful when dealing with rare diseases, because you ideally would like to have the active compound given to everybody, rather than having patients receiving placebo, patients receiving the active medication. If you know what the natural history of the disease is, then it's possible to design trials where you're looking is a modification of a trajectory that is already well known.
Yeah, no, absolutely. So I think the short answer would be, try to be as involved with the research as possible, because that really is what lays the groundwork for any kind of future treatment, and kind of for any kind of future therapy. I think we might have, time for just one more question. I think, Camilo, there were some questions about, are there any specific multivitamins or any kind of treatment that would be helpful? So one question was, how do you manage weight when you cannot exercise? I know, very briefly, if you can just touch on them in general. I think, yeah.
So, I mean, this is not particular to this condition. You'll see this in any disease that affects mobility, is that it becomes difficult to maintain weight. It definitely impacts as you gain weight and your mobility is compromised. Then it creates an extra challenge. I think working with a physical therapist, with an occupational therapy team, to consider a regular exercise program will be beneficial across the board. I don't know of a particular diet that will work other than just a general good diet. People talk about Mediterranean diets as being good generally in terms of helping cardiovascular health, and definitely manage coexisting conditions. that actually is critical.
Great, thank you. I think, I'm getting an email, chat message saying that we are pretty much done. I think we have kind of less than a minute there. So I will just kind of want to conclude and first of all, thank Lisa and Camilo for, taking time. I really appreciate that. And the ULF especially for kind of putting this together. It's been so important. Please be involved in the research. I will be emailing many of you with some of the websites that Camilo had mentioned. And just want to put out there that I think a lot of you already know that there is a Facebook group that is already being set up by some of you, so I think you should definitely look at that. And that is also a kind of useful resource to kind of look out there. I think that's pretty much it. I think we are done. I think we're done with our time. And again, I would like to thank every one of you. And, I look forward to working with you in the future.
Thank you for listening.
Yeah, thank you. Bye.